Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins. I'm Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
1 minute you're fine, the next minute you're crying over an ad for a dish soap or plotting your partner's mysterious disappearance. If this sounds familiar, welcome to the Menopausal Mind. Today, we're unpacking the real science behind mood swings, rage, and mental health changes during perimenopause and menopause. Spoiler, it's not all in your head, but your brain is very much part of your endocrine system.
So we'll talk hormones, misdiagnoses, why SSRIs don't fit everything, and a brilliant clinical tool most clinicians still don't know exists, the MinOD questionnaire by Professor Jayashri Kulkarni in Australia. If you're a clinician, this is your cue to grab a pen. If you're living it, this episode might just make you feel seen.
Buckle up. This isn't going to be a gentle mood board. It's a full-blown hormone reality check. And yes, we're going to talk about rage. Sweet, misunderstood rage. Welcome back to the Dusty Muffins. Well, girls, today we're going to talk a little bit about something that we've touched on plenty of times, but never really delved into, and all the mood issues that we go through during perimenopause and menopause. I think we've all lived through that. Or currently living through it. And I think what most of us as clinicians don't realize and are not taught when we're going through our training is that estrogen is so integral even in the production of our neurotransmitters. So for instance, serotonin. So estrogen boosts serotonin production. And it increases the number of serotonin receptors and slows serotonin breakdown, which is massive. You know, this is what we treat depression with, SSRIs, selective serotonin reuptake inhibitors. So this is our natural serotonin reuptake inhibitors. When it comes to dopamine, you know, a lot of women will say they get ADHD symptoms during perimenopause, and for some women that is an unmasking of their actual ADHD that's never been diagnosed, and for others, if you just treat them with hormones, the symptoms go away because it's actually the effect that losing your hormones has on your dopamine. So estrogen enhances dopamine synthesis and receptor sensitivity in key brain areas like the prefrontal cortex and the striatum. So that sharpens motivation, focus, and reward processing. Basically, it's the get up and go factor. And then your low estrogen can flatten that drive, making everything else feel a bit beige. And our GABA receptors, of course, estrogen modulates GABAergic activity and increases GABA receptor function. It's our brain's chill neurotransmitter, and we know ourselves as well that progesterone plays a major role in that too.
Yeah. And you know, the thing that's interesting about the serotonin is, and this is the thing that I struggle with clinical care, is when, so many patients come to us because their providers only offered them like an SSRI. And, that is just outraging for them because they, believe that all of that is related to their hormones. But then when we get their hormones optimized, they still have a lot of, either depressive or anxiety or ragey symptoms. And I find it really challenging, to help women understand that the hormones aren't going to help everything, and that
Yep.
sometimes you need to be on a mood enhancing medication to help boost that serotonin. And I think that's important for women to know. And the answer isn't, well, we'll just keep going up on your hormones. Sometimes
Right.
you just need something for your mood.
Yeah, you do. And you know what's interesting about that is I feel like perimenopause is when we're the most vulnerable to that. Because again, if we're using menopausal hormone therapy, we're not shutting ovaries down, right? And so
Yes.
your hormone optimization may still not be enough to support the mood changes and the serotonin and dopamine and GABA, all of the neurotransmitters that affect your mood, or kind of like some of what our other colleagues have went through. Sometimes you need to put them on something because the hormones are not going to work fast enough and they're really in a dark place, or the anxiety is so overwhelming that they may need, and then maybe it's a short term, they may need an SSRI, they may need something, or a SNRI, or some other type of medication to help stabilize that mood. And then you can optimize your hormones and then perhaps try to get them off if you can. But there are some women that they just are really in a very detrimental place and space with their mental health that they do need help right away with something before we can optimize their hormones.
So true. And even the Menopause Society released a practice pearl talking about this, and kind of went through the evidence that we have. And even since that, there's been more evidence. But, very often during perimenopause, the root cause is hormones. And so you should reach for the hormones first, see how they work. And like you said, Christine, then add in your antidepressant if you need it. And then after menopause, for a lot of women, it's actually the SSRI can work a little bit better. Not that hormones don't work too, but you could reach, it would be understandable to reach for the antidepressant first. But I think the more information we gather, it'll become more and more clear that during perimenopause, the treatment is hormonal.
Mm-hmm.
Mhm. Yeah,
Yep.
absolutely.
Yeah, it is. And I think the important topic with that is it's not a one size fits all, and not everyone is going to get the same type of outcome as their friend, or so we have to try those things, and you have to be patient. If I can drill home to women every single day the ability to be patient, so we can really see how you're going to respond to to this hormonal support, if we're using menopausal dosing, because it's not a failure. We're not shutting those ovaries down. So we're following you around with a little cushion and trampoline to like support you. And so I know they get so frustrated, and we're here to tell you that we're not frustrated. We understand it. It's just a matter of really understanding these emotional highs and lows, and sometimes we get it right the first time, but oftentimes we have to fine tune things as you go through that transition. Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
So true. And I would say we see so many perimenopausal women who come into us and say, they've developed this new or worsening anxiety and difficulty getting to sleep. And for us, that means progesterone is dropping, doesn't it? We can pretty much, yeah. So that's really the first thing we notice as you go through peri, your progesterone levels drop and you're lying there looking at the ceiling, trying to get to sleep, watching the clock, worried about someone coming to steal your kids or driving over bridges, things that you might never have worried about before. It does feel different, doesn't it? The anxiety that women get in perimenopause and anxiety that we've always dealt with as clinicians otherwise.
Yeah, I think so, for sure.
Yeah.
It's out of nowhere. It doesn't make sense. You've never felt it before. And women are really in tune to when they're like, listen, this is not my typical anxiety. Like I get this is my anxiety over here. This is different. This is
Yes.
not my norm. They're really, really good at being able to, I think, delineate between those two, right?
Yeah. Again and again, we come back to listen to your patient, like it's our job is kind of easy in a way, because all we have to do is listen. And so often our patients will just tell us exactly what's going on. And if you are lucky enough to know about hormones, then you can piece the pieces together and make it make sense. And then, more of I think, well, of course, depression can be caused by that lack of sleep, that now you're not sleeping anymore, right?
Right.
And you're feeling anxious. So I feel like it's all on a spectrum. You can reach a point then where depression comes in, but definitely estrogen plays a role in that, doesn't it?
Yep. It's the largest receptor site is in your brain. It's estrogen is the largest receptor site. So, it's always great when you do get patients optimized, and then, everything clicks back into place for them. It's a great feeling as a clinician, that's for sure.
Mm. And patients will say rage is a big thing. Very often my patients will come in and say, like, I hate being like this with my kids. I'm so snappy. I flip the lid really quickly. I love my partner, but I want to murder them. And and the rage, like the irritability and the rage, really, really bothers women.
Yeah. No one wants to feel that way. They don't understand it. They feel bad. I think one of our friends and colleagues is, quotes the Perry monster, like that's for our kids is Scary Perry coming out, Samita. So, but it's true, it just, and then you feel bad, right? You lash out and then you're just like, oh my gosh, why did I do that?
I know. And you just have to own that shit like a badass, and then have be humble enough to apologize, which is why it's so important for spouses and even kids to kind of understand it. So, that it helps, I think, helps them deal with us a little bit more if they come from the, if they can kind of poke fun at us, maybe not too loudly. I think then it helps them. And then maybe, it just makes it better versus then the whole family's in a fight.
Right. Or teach, I think, or even just teaching your family your, safe words or safe quotes, like saying, because they're used to like, okay, mom could do all of these things. We could all talk at her at once 5 years ago. Right. So now when you say something like, you guys, I'm overstimulated. I need one person at a time, or I can only deal with this right now. I can't do it. Like, I think they have to then just be like, okay, this is mom's, like, this is her warning, right? Before something not good may happen. And the same thing I think with our spouses too, right? We're tired, we need sleep, or if we're hungry, our fuses are just not as long as they used to be for, I need to get some sleep, I need to get some food, I need to get some rest. I can't do, 10 different things. I really now can just do 5 or 3 or 2 or 1 now. And so those types of things are truth. I mean, I know that I definitely cannot multitask the way I used to multitask, and I get very overstimulated and overwhelmed now when, if everyone starts talking to me at once, I'm just like, okay, guys, like 1% at a time here. And so that open communication, I think, with your family, and then your family taking that and not making fun of you for it, but supporting you.
And if you're a woman who has a history of childhood trauma or PMS, PMDD, postpartum depression or baby blues, we see it in women who have ADHD and autism and endometriosis, women whose bodies and brains are very sensitive to hormonal changes, then menopause can be tougher for you, and you can get more brain symptoms.
Yeah. Yep, absolutely. I think,
which is really important to know.
And we talked a little, we touched a little bit about kind of like the clinical realities and misdiagnoses, the fact that, there's hormone related mood issues. We know that, right? PMDD, like you were saying, PMS, versus really those primary psychiatric illnesses, depression, anxiety, bipolar disorder, ADHD, especially in the Gen X population. I think, those just weren't things that we were really diagnosed with as kids. And so we're, a lot of adult ADHD, I think, just came from our Gen X, finally being diagnosed with something like that. And so, you are going to have your perimenopause along with some of these other general psychiatric conditions. And so you may notice that it's exacerbated or it's getting worse, right? Your ADHD is getting worse. I hear my women tell me that all the time. My anxiety is worse. This is not my baseline. I was really controlled on my medications, doing really, really well. And now all of a sudden my anxiety is worse. My depression is worse. I cannot focus. I was doing really well on my medications and now I can't focus. So that's when we know, like, okay, we don't necessarily have to increase the SSRI. We don't have to necessarily increase the mood stabilizer that they were on or that they are on. We don't necessarily have to give them more of a stimulant or whatnot, but this is more hormonal. And if we can, help optimize that as much as we can optimize in peri, that then may bring them back to their baseline, or is at least as close to their baseline that they were in.
There's a woman on Instagram. I wanted to read this out to you. ADHD _with_ Dr. Jen. I love her posts. And she put one up yesterday and it was, anyone, why are women suddenly getting diagnosed with ADHD now? And then Dr. Jen's answer, because survival mode expired. The good girl act collapsed. Perfectionism broke. And perimenopause pushed us past our limit. We can't fake it anymore. Yeah. I just thought that was wonderful and would probably resonate with a lot of people.
Yeah, I'll tell you, when I was at the worst part of my perimenopause, I truly was like talking to my colleagues. I'm like, do you think I need some, Wellbutrin? I don't know that I don't want a stimulant, blah, 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 blah. And, I really remember looking at my husband who has horrible ADHD. And I'm like, is this what your brain is like every day? I'm like, I can't do this. Like, how do you do this? Like it reminds me of that, like Fraggle Rock. Do you guys remember like Fraggle Rock?
I love Fraggle Rock.
Like, the eyeballs going in all like different directions.
Yeah.
I was like, ooh.
Again, the same.
Maybe we need to get the Fraggle Rock for the
oh my god, I love
thumbnail
Fraggle
of
Rock.
This. So did I. I loved Fraggle Rock. I don't even know where I pulled that from in my perimenopause brain, by the way.
Well, you were imagining yourself like that weird Barbie. Yeah,
the hair up and the people would know the other type of Barbie that's
the weird Barbie.
The weird Barbie. The millennial generation will get the weird Barbie, but Fraggle Rock, with the eyes going. There's, I mean, geez,
It's rough. I know. And we're big fans of us. Go ahead, Christine.
No, go ahead. What are you a big fan of? And then
I was going to say we're all big fans of Dr. Louise Newson in the UK, and she's so good about drawing attention to women's mental health with regards to hormones, and just has so many patients on her podcast who tell a story of the cause of their anxiety and depression being missed again and again and again. And so even the first time they see a doctor, second doctor, third doctor, they take a whole history, an amazing history. So you have premenstrual syndrome your whole life. Oh, PMTT. Oh, you have postpartum depression. And, so the patient is sitting in front of them saying, I've had these symptoms before during times of my life that were massive hormonal fluctuations. And it is all going over the doctor's head. They don't catch on to any of it because we're not taught about any of it. Yeah.
Yeah, I remember I had some of my very first patients that came to me with like extreme depression, like extreme anxiety, mood changes from hormones. I remember as a clinician feeling, thinking, oh my gosh, this is really scary. And even needing to make contracts with patients, getting spouses involved, because the patients, were so, convinced that it was completely all hormonally driven. And I remember in some of those early cases, I wasn't so convinced it was all hormonally driven, but it was so fantastic to see them come back in 4 weeks later, still safe, and checking on them along the way, and just watching that veil be lifted. And I think, these are patients where the providers kept upping their medications, and the depression was getting worse and worse. And, when hormones are the primary cause of mood disorders, SSRIs are going to be ineffective. So if you keep having to increase it and you're not getting the results, it's probably something else that you need to do, because if you don't address the root cause, which is that hormonal imbalance, you're not going to get success. And, medications like SSRIs are designed to increase the level of serotonin in the brain. But if the issue is related to those hormonal fluctuations, the serotonin system cannot function properly, no matter how much serotonin is available. In essence, it's a structural problem and not a supply and demand. And that's where you need to be thinking about hormones and not increasing those doses.
Yep. I like that. And essentially what, that quote up here is, if you only look through the psychiatric lens, you'll miss the hormones waving frantically in the back. And that is, that's fantastic. It's a really great way to, to segue into the next section, and just for clinicians listening to this, and even women who are going through this, to remind your clinicians too, that, let's not miss the hormonal part.
Yeah.
I just want to do confessions about what Aoife's going to talk about next. I had never heard of this questionnaire. I don't know how I missed it. So I am waiting with bated breath to be educated, Dr.
Well, that's why I wanted to use our podcast and this platform that we have to talk about it, because people don't know about it. So over in Australia, there's an incredible educator and psychiatrist, Dr. Jayashri Kulkarni. And she was one of the doctors who spoke at the So Hot Right Now conference in the Sydney Opera House and reached all those thousands of women. Yeah. And she realized that the anxiety and depression that you get during perimenopause and menopause is different to your garden variety anxiety and depression that you see as a primary care doctor or a psychiatrist in the community. And she wanted to kind of dig down a little bit, because we have some questionnaires that are very helpful for anxiety and depression. One's called the PHQ-9, which is for depression. One's called the GAD-7, which is for anxiety. And they will be very helpful picking up on your garden variety anxiety and depression, but they don't do a great job when it's due to hormones. And so I just pulled up here, there's 12 questions. It's called the Meno-D questionnaire. And she asks 12 questions and you score it from 0 to 4. And the 12 are irritability, anxiety, mood swings, low mood or depression, loss of confidence, reduced motivation or drive, sleep disturbance, fatigue or low energy, concentration or memory problems like brain fog, feeling overwhelmed or unable to cope, loss of enjoyment, and then physical symptoms impacting your mood, like hot flashes, night sweats, palpitations. And so I really feel that gives you a better feel for whether it's your anxiety and depression that you've always had, or we've learned about and been taught about, or it's more to do with hormones. What do you think of that?
Do you use this now, Aoife, instead of PHQ-9 and GAD-7?
I tend to do the PHQ-2 initially, just on the intake form, to catch if anyone is having some depression or anxiety symptoms. And then I'll tend to do the Meno-D just face to face with my patient, going through the symptoms with them. Yeah.
So that's
when I see
that's quite a bit, quite a few. Like I was looking through the Meno-D rating scale. So it's got like an A through what? G, H? No, more than that.
Yeah. Well, I keep it pretty
pages, right?
Yeah, you can get it's very thorough. But for me, just asking about the feeling, the overwhelm, and then the physical symptoms that might be. So it goes a little further than the other questionnaires do, to give you a sense of where's this actually coming from.
Yeah.
So
I want to ask other clinicians, because I think we're all looking for how do we best assess our patients. So I think this is really pretty incredible, because you're right. A lot of it is, in low, low self-esteem, not sleeping for a long time, and,
Yeah.
breaks down your resiliency. And so, the PHQ-9 and the GAD-7 never really felt right, but that's what we were taught to use. And so I'm really excited for this new tool. And
Yeah,
patients
that's
can
really great.
access this as well, correct? So if they want to give it a whirl, regardless if their clinician does this.
Oh, yeah. So Dr. Kulkarni works at Monash University in
Yeah, I did.
Australia, and it's on their website for free. So you can just put into Google search Meno-D, a PDF, and it will come up. And the nice thing is that you can incorporate it into your EMR and just send it to the patient
Yep.
with their intake forms, and they can have it all done before you ever see them.
Yeah.
Or if you're in person, you can ask them to do it in the waiting room while they're waiting to see you. It takes 5 minutes.
Okay. So now when it talks about, moderate perimenopausal depression versus severe perimenopausal depression, now are they the way to interpret that? Then are we treating with hormones? Are we then needing to treat with a different modality?
I think it's to get a sense of what's going on. And if by the time you finish the questionnaire and gone through it with the patient, you feel that it could be hormonal, then you start hormone treatment and then repeat the questionnaire as you go
Kind of
along.
like our green scale score.
Yes.
So you like to use this in conjunction with both of those.
Exactly.
So,
yeah.
Yeah.
Because I have a patient who has a lot of mood symptoms. And so I really got a sense from her that that might be hormonal. And so we started hormones, didn't notice very much, went up on the dose, didn't notice very much. And at that point, I said to her, this is not how things normally go if your symptoms are from hormones. Usually we will feel an effect. You'll feel an effect by now. Even if it's just changing a few symptoms, like definitely you feel your mood has lifted. So that makes me suspicious then that we are barking up the wrong tree, and maybe she does need an actual antidepressant to help.
Yeah, because this is between 20 to 24 points is considered mild perimenopausal depression needing monitoring. 24 to 32 is perimenopausal depression needing treatment, and 32 and above is severe needing treatment. So that's really very, very, and kind of speaks then to the same, to what I was saying before about, when do you continue hormone therapy but add on other things?
Yep.
Yeah,
Right.
it's another tool in our tool belt, isn't
Right.
it?
Yes, that's exactly what I was going to say. And I think that's one of the things that, when you women, when you are seeking out a clinician, it's really important that they have multiple tools. And it's this, we're treating things based on then how you feel too, especially in perimenopause. We don't have a lab that says, yep, that's it. It's great. So we may push forward and increase something, and it may work, it may not. And then maybe we have to back off. So it really is all, I know women sometimes get frustrated because they're like, I want something that makes me feel good right now. And we may not find that right away. Sometimes we get lucky and we put them on some progesterone and they sail off into the sunset for a while and they do really well. But I know I've said this a few times, and maybe it's just because I feel like we are just, our education in our perimenopausal patients and what to expect and what is happening, I think could be better. And I'm trying to work hard. I know both of you do as well in your own clients, but I think that even just in social media, when we're giving this, education to women, that we need to really make it clear that that this is support, and we may not make you feel completely fantastic until your ovaries kind of peace out and are done. And even then, we're just not sure what our new midlife normal is. It may be better than our 30s. It may not be quite there. It may be the same. So
it makes me laugh when you hear,
feeling off in midlife? I'm Dr. Rebbecca Hertel, and I offer concierge telemedicine across multiple states focused on hormones, weight, libido, and sleep, and longevity. Let's get you thriving. So visit www.osteopathicmidlifehealth.com.
And I could be completely wrong, but you'll hear said that when you're monitoring women's mood and their view on their quality of life as they go through perimenopause, it's really bad. And then after menopause, it really improves. And I'm like, yeah, if a woman feels like she's going to die for 10 years and then she no longer feels like she's going to die, that can feel amazing, but doesn't necessarily mean that you're back to, feeling great.
Yeah, right. I think it's very true. That I would say is the worst transition, like how many days I'm just like, can it be just menopause already? So I know that I have 0 left and then we know where to go.
Yes.
Then
the only way is up.
Up and down is for the birds. Forget it.
I like to tell people, women during this time, that this is the time to be as selfish as you possibly can and to prioritize yourself. Because if you don't, this is a really rotten and wild ride. Exercise is such a great way to build resiliency, boost your endorphins, and, just help you, build muscle and feel good about yourself. And, working that into your day. I mean, personally, I think, you have to, if you want to live the next 40 years, you just have to make exercise a part of what you do, just like you brush your teeth. And if you don't build it into your day, usually before your day begins, there's a million reasons why it doesn't happen. And sleep. I used to be really bad about watching TV, but now that my husband wakes up at 4:15 in the morning, thank you, government, for sending him back to work. I felt kind of bad, with the TV on, which is terrible, right? All that blue light and the TV, and wind yourself up depending on what you're listening to. And so now I've gotten in the habit of reading, which I used to really like to do, but I never could find time because I wouldn't put my phone down. I've stopped scrolling at night and I don't watch TV. I do read, and that, really, really, really helps. And, I then found myself really turning to, wine. I love wine. Wine doesn't love me, but I realized I was using it a bit as a coping mechanism during perimenopause. And I'm like, I know that the wine that, the bottle, a bottle really fits into a wine glass, but that's not probably an appropriate pour. And one of the things that, has taken me a really long time, and I'm finally making that menopause transition, at least my labs say I am, that I think, when Aoife, you talked about, things that happen before, really kind of, can make this more difficult. I actually had a postpartum depression with an inpatient psychiatric admission. And, I have always coped by not doing therapy, just working harder, going from the next promotion to the next job. And then, I think people have heard me talk about the fact, my perimenopause when I up and quit my job. But I think a lot of that was not dealing with the grief of the loss of my daughter. And then this in April, which I don't think I've been really, I haven't been that forward with that. I did lose my mom. I'm going to start crying now. And I finally decided that I needed to be in therapy. And so finding a therapist and not being afraid to do those things, I think is really important, because I think the perimenopause hormonal roller coaster, all of your past experiences just come crashing together. And I think not being afraid to get that help is really important.
Yep. Absolutely.
Sorry.
Thanks for...
No, we know that traumatic, all the trauma as a child, an adult, and not to mention just, the unheard of things that women go through, like what you have gone through. All of those things get exacerbated and make your perimenopause worse, and that menopause transition word, right? Lifestyle, our, life events, traumatic life events. And I think you're right. I think you can put everything to the background for so long. And then all of a sudden you're in this perimenopausal state where you're so vulnerable because your hormones are just wreaking havoc. And then all your coping mechanisms that you used to cope with, which you really weren't coping, right? We were just throwing all of this shit back here for a while. And then you're just like, this isn't working anymore. And you just find everything kind of starts kind of coming on down, and it takes
This
a
is
lot
the time
to say,
to put yourself first and
you
get things fixed. All the things that you've been avoiding, fix it. Do it. Make the time. Mm-hmm.
Yeah, you have
Thanks
to.
for sharing all of that with our listeners, Christine. I think that'll reach a lot of people when they hear how you pieced it together, and what you needed in the end, and maybe that'll help somebody listening.
I hope so.
And it's it's a lot to open up, like that. And I know, it's hard. It's hard for us. It's hard for, I think you, Christine, with even just a military background, right? You just don't talk about those types of things. And I think Gen X women, we were, seen and not heard, and we just suck it up, buttercup type of thing. And, you can only do that for so long. And
Absolutely.
then you just can't.
No, but the more we talk about it, the more we name it, normalize it, channel it, take ownership of it. I mean, I think, it's important. And I think it's important, for other women to see women, obviously, 10 years ago, nobody talked about, depression, anxiety. It was, very much, what happened, behind closed doors, and used to run into mental health. And at least in the military, you'd try to get in the door, but and hope to heaven that nobody saw you in the office, and please not be an airman that you sent there, seeing you do that. But, there's no shame in, having difficulty. There's no shame in being on medication. What is unfortunate is when you don't take the steps, and, you've been so busy taking care of everybody else that you just don't make time to deal with it yourself. And at a certain point, it does come to a head, and, and that presents in different ways for different people. But, I think the most powerful thing is to be able to be okay with it. It doesn't make you broken. It just makes you human.
Yeah, it does. And talking about those things, and talking about, things that are uncomfortable, because if we don't, they, like you said, they come up at some point and rear their head, at some point when you're not dealing with, my sister and I talk about a lot how it took us 10 plus years to deal with just the death of our sister. And because of life at the time, right? Life was lifing, and we needed to life along with it. And, but it always comes back at some point, and you have to take that time. You have to take the time to grieve, to feel, to yell, to scream, to cry, to laugh, to, feel all the feels, even though it's not comfortable feeling those feels sometimes. But that's how we heal. And that's how we heal ourselves. So that way we're better for ourselves, and then better for the other people that we love.
Exactly.
Culturally in America, we are not good at grieving, stopping and grieving, with work and other family concerns. And there's no time to actually stop and grieve. Like some other cultures are better at that, definitely.
Yeah. Yeah.
Absolutely.
I think
it took me 10 years. 11. Yeah. I'm doing it now. I don't know if doing it but at least I'm optimized. So maybe it is the right time.
Sometimes you never know when it happens. Stuff just happens, and you're just like, yeah. And then your brain's finally like, listen, I'm not, all those things that happened, in your life, it's time to deal with them now, sister, whether you want to or not. That's what the brain does, right?
I am.
The brain's like, it's time.
What?
Avoidance is so much
I
easier.
said I'm really good at avoidance in therapy, and that damn therapist, she keeps coming back to it. I'm like, I want to talk about something stupid. She's like, yeah, no, we're going back. I'm like,
Yep. Isn't that what we do with our patients? You know, some of my primary care patients, I'm like, let's talk about this. This is the place that you get to scream, cry, all the things. I just did this probably about a week or two ago. And someone I've taken care of for a long time has had a couple of losses. And, you know, I just sat there and I'm like, this is where you get to do all of that right here, you know? And we shouldn't have to give someone permission to grieve. But it's okay to do that in whichever way. And it doesn't take one time. You know, grief is a weird thing. It's not linear. It is up and down and all around. And, you know, even when all those years pass, it still takes a smell or a sound or a song or, you know, to bring a lot of those feelings back. And so, you know, grieving, it should not be something that we try to, I can't think of the word now because of my own perimenopause brain, that we're ashamed of. Right.
Yeah.
So absolutely. So are we gonna play this game, mood myth or mood truth?
Yeah. Let's do it.
Right.
Kick us off, Rebbecca.
Okay. Do I answer it too or no?
No, we'll all answer together.
Okay. So rage
you mean
is
in
your
unison?
new...
We suck at doing that.
Oh yeah, we do, because there is a delay.
All right.
How about the next? All right. Rage is your new personality. True or false?
False.
Yes.
Doesn't have to be. If your PHQ-9 questionnaire is normal, mood issues aren't real. True or false? False.
All righty. Hormone therapy fixes everything. Doesn't it? True or false?
False.
Oh, we want it to be true.
We wish.
Menopause is just midlife stress. True or false?
Fuck that.
False.
Oh.
Fuck that. Antidepressants don't work if hormones are involved. True or false? False. Definitely. Yes.
False.
We use all the tools in our toolbox.
All the tools in our clutch bag, for sure. All right, take it away, Aoife.
Mood changes in perimenopause are not character flaws. They're biological, hormonal, and completely valid. And most importantly, they are treatable.
If you're a clinician, go look up the MenoD questionnaire. It's free, it's validated, and it will change how you... I can't read this. Spot menopause-related depression. Stop relying on PHQ-9 alone. It's missing half the story.
And if you're someone living this, you know that you're not broken. There are answers, treatments, and support. You don't just need people who know where to look.
Share this episode with a friend, a colleague, or a doctor who needs a little hormonal enlightenment. Follow, subscribe, leave us a review because the algorithm needs a mood boost too.
And remember, keep your hormones balanced and your rage strategically deployed.